Okay, good evening, everyone, all my teachers and my colleagues. It's indeed an honor to share the dais with so many eminent people whom we have all grown up looking up to, and probably the showing of technique by a junior is just to rectify his mistakes, and over a period of time, if any mistakes have been done, I'm sure that we will be corrected in a proper way. First, answering the question that Dr. Bala had put up initially as why to go ahead for intervention nephrology. I actually underwent the training in a center in East India in Calcutta where the interventional nephrology was pretty much non-existent, and the learning curve has been quite long for me because there was no one to teach us, and we went through a lot of hit and trial methods and went all over the place to learn the technique. And eventually, since I belong to Sikkim, so I settled down in Siliguri, which is a small town in West Bengal near Sikkim, where I had decided to settle down. When I had come here, the medical college which is present in this area doesn't even have a maintenance dialysis unit. At least it didn't have at that time, and we just had, I think, around 35 or 40 hemodialysis machines, which was catering to probably around 4 or 5 crore population in the nearby areas. So the situation was pretty much bad, and there was no one to call for PD catheter insertions or tunnel catheter insertions, or even a biopsy was unheard of at that time. So that is the reason that we had to venture up into the procedure. And eventually, after many years, the specialty is well established in this part of the country, and I'm very happy that the patients are able to avail all the facilities of modern care. And all the techniques that I will be telling are a modification of what is done in a resource limited setting, because that's the setting where I have been practicing over a period of time, and additional methods I will keep adding on if it can be added to the presentation. So I think I'll go ahead with the presentation, sir.
Yes, yes, please.
There's a spelling mistake in the first slide. I'm sorry for that. Okay, so the first question is why peritoneal dialysis? We all know that this is a very long debate as to whether PD is better or hemodialysis is better. Most of the meta-analysis and early publications were biased against peritoneal dialysis because it was always looked at as a salvage technique in people who are not able to undergo hemodialysis for a long time, or they had nothing to fall back to. That's why many of the earlier studies were biased against PD, and it showed a little inferior long-term survival in peritoneal dialysis. But recently, many studies have come up in which if we choose PD as the first method and compare it with hemodialysis, the short-term as well as long-term modality is very much similar. So there is nothing against peritoneal dialysis in the modern setting, and PD is a good RRT methodology. Why peritoneal dialysis? Most of the nephrologists in India, they practice in the metro cities, and almost all the patients have good access towards hemodialysis units. But nephrologists like myself and those who belong to the Himalayan region or the northeastern region, we have a lot of problems in calling the patients for hemodialysis. Now, this is the rosy picture that all the people coming to my place they end up seeing it. This is Darjeeling, and it looks quite beautiful. And this is the North Sikkim, and it looks as beautiful. Probably Dr. Adil Beg belongs to a place which is even more beautiful than this. But the beauty does not apply to patients because it's a very sparsely populated area, and the hemodialysis centers are very far away located, and people have to travel long distances to reach a dialysis center. And in the monsoon, this is what happens to my place. So all the roads tends to get blocked because of recurrent landslides and all those things. So it's a pretty much in a bad shape in the monsoons. These are all the pictures of this monsoon this year. And you can imagine what happens to a hemodialysis patient if they have to travel through this sort of routes to go to a dialysis. So PD has been successful in my place because the acceptance is better because of these reasons. And we have been inserting PD regularly for the last few years because of the increased acceptance. Now, coming to why the nephrologist should be involved in PD catheter placement, as it was in this Medicaid data, even in our country also, many of the PD catheter insertion is not done by nephrologists. They are usually done by surgeons or urologists who are working in the same place. Now, many of the nephrologists are being trained in interventional nephrology, and they are putting it, but the picture is still bad. And since we are the ones who are directly involved in patient care, and we'll be able to convince the patients better in accepting PD as a modality. So there's an increase of patients when a nephrologist gets involved in CAPD catheter insertion. And this study had shown that when it was again given back to the surgeons, the PD acceptance had fallen down. So nephrologists have to step up in PD catheter placements and have to start doing interventions. So a few methods of PD catheter insertion that we all know are the surgical, laparoscopic, peritoneoscopic method. These are all usually done by surgeons in most of the places. Few interventional nephrologists are venturing into laparoscopic and peritoneoscopic, not so much in India, I guess. And the blind percutaneous technique is the one which remains with us, which can be modified by ultrasound guidance, as the previous speaker had told, and further made safer by fluoroscopic guidance. The talk for today's topic for today's talk is the blind percutaneous technique. So I'll be going ahead with an example of one of my patients and the other additional inputs that I'll go ahead. How do we select patients? For a simple baseline rule, avoid selecting a few types of patients for doing a percutaneous daycare procedure, especially if a patient is very obese, if the patient has significant cardiovascular disease, especially if they are orthopnic, they have had multiple abdominal surgeries, especially the dirty abdominal surgeries. Anxious patient who need deeper anesthesia should be avoided as a daycare procedure, and people having intra-abdominal pathologies should be avoided to decrease the complications. We take a full informed consent. A shower is advised in the morning, hair clipping if required. A patient has to pass the urine, or if unable to pass urine, they have to be catheterized before the procedure to avoid bladder injury. Avoid perioperative constipation, and enema is usually not needed for a percutaneous placement. Prophylactic antibiotics in the form of vancomycin or cefazolin, depending on the local antibiotic profile, can be given 1 or 2 hours prior to the procedure. And if needed, a light sedation can be given in the form of daycare sedations. Either you can choose one of these sedatives if needed. Many of the patients might not need sedation if they are properly counseled and if the insertion technique is swift. We need a bedside monitors because most of these patients are having cardiovascular problems, and we prepare the skin with any suitable scrub like any other surgical procedure. This is the picture of the daycare procedure in my center, where we do PD catheters. This is a simple setup that is all needed in a percutaneous PD catheter placement: a good lighting, proper surgical cleanliness, and gloves, masks, and all the other things that are needed in a minor OT procedure. So how do you select catheters? A few catheters which we all know are the dual cuffed straight or a curved Tinkoff catheter. Swan neck catheters are also available, but we are all mostly trained in using the straight catheters. So I will be going ahead with the straight catheter placement. The last one is used for morbidly obese patients, where we have to extend the catheters to the pre-sternal region. How do you consider catheter selection? It is considered based on the belt line. If the patient is a male, they usually tie their belt below the umbilicus, and we tend to select the straight catheters where the exit side is kept above the level of the belt. In females, since they tend to tie their clothes above the umbilicus, so a swan neck might be preferable for them so that the catheter goes below the belt line. We have to avoid the skin scars, folds, and creases. Again, morbidly obese patients might need an extension into the pre-sternal region because of the abdominal anatomy. Handedness is important because a right-handed person will be better able to perform the PD if the catheter exercise is on the left side because of dexterity of the right hand. People who are involved in SOBEs will not like their catheter to be sticking out of the above the bed line. So using a swan neck will be better in this sort of patients. If a patient sleeps on the right side, exit side on the left side is better. And again, if there are other abdominal stomas, keep it far away from the stoma so that the peritonitis rates comes down. So these are the few ways in which we select the type of catheter and as well as the shape of the catheter. This is the usual available percutaneous PD set, which contains all these instruments. The usual things that we need, especially the available in the sets, are the P-Lovi sheath and the dilator and the stylet. The other things can be bought separately as well, but in the PD set, usually the stylet and the P-Lovi sheaths are separately available, and this makes life much easier for us. So how do you choose the incision site? A rough guide of choosing insertion site is to make sure that the tip of the catheter is neither floating in the abdomen so that it will be malpositioned, or neither it will be too deep into the pelvis so that it gets trapped in between the viscera. So a rough way to find it out is by placing the symphysis pubis as a marker. So you keep the upper part of the curve of the Tenkov catheter right at the level of the symphysis, and then trace the deeper cuff in the paramedian region. If you are using a straight catheter, then it is preferable to start measuring by leaving a 5 centimeter tip at the bottom, and then measure it from there up to the insertion site. This is how in this patient we have measured by placing the upper part of the curve at the level of the symphysis and the deep cuff at the paramedian region, so that we know exactly where the exit site and the deep cuff should be placed. Now, choosing the paramedian site is useful because placing it through the median site increases the risk of early catheter leaks and hernias and all those things. And it has been shown that placing it through the rectus or above the rectus reduces the chances of immediate or late catheter leaks. But again, since the epigastric vascular bundle lies along the posterior rectus sheath, as was shown by the previous speaker, so if we have an ultrasound, then we can use a Doppler and trace the epigastric artery. If not, then a rough guide would be to take a point of around 2 to 3 centimeters in the paramedian region, tell the patient to lift his head and make the rectus taut, and don't choose the midline of the rectus, and just medially to the midline of the rectus would be a safe place. But again, if you have an ultrasound and a Doppler, it again makes life much easier. Then we infiltrate the skin with 2% lidocaine and infiltrate it up to the level of the peritoneum, and 10 to 20 cc is enough for achieving a good sedation. This is one technique which I have actually found out later on as I was putting the catheters, by putting the stylet which is available for tunneling into the proximal pore of one of the coils. So this causes the catheter to be straightened up like a stylet. So if you use a stylet, then you might need a longer stylet which is put through the entire length of the catheter. But this is a modification of using the stylet for straightening the catheter so that it reaches the pelvis, and since it is made in such a way that the tip of the stylet never comes out of the tip of the coil. So a blunt end is always left behind, so it does not cause visceral injury. After that, we use the introducer needle, and you can use saline, or you can use Visipic loaded in the saline, and you insert it through the anterabdominal wall at around 45-degree angle pointed towards the pelvis. And as you puncture the posterior rectus sheath, you have, over a period of time, you tend to feel a giveaway sensation, and you know that you're inside the abdominal cavity. Again, fluoro guidance is safer. I will show how the fluoro looks once we push the dye, once we're inside. Once the introducer is inside, then we can put the guide wire through the introducer. And again, the direction of the guide wire insertion should be kept in such a way that it's at a 45-degree angle and the guide wire goes into the pelvis, and it does not get coiled in the upper abdomen that way. So this is the fluoroscopic picture. Once we have the introducer in place, we push the Visipic, around 10 to 20 cc of Visipic, and we can see it spilling into the abdominal cavity, and we know that we are safely inside. Once we are also putting the guide wire inside, we can use the same C-arm and find out the guide wire coiling up in the lower abdominal cavity, and we know that we're safely inside the cavity. If we do not have a fluoro guidance and resources do not permit fluoro, then you have to instill 1 to 2 liters of saline or a dialysate through the introducer needle before putting the guide wire, to eliminate the risk of bowel injury, so that the bowel tends to move away and the chances of bowel injury goes down. After putting the guide wire, a bedside X-ray also can be used to confirm the position of the guide wire if you do not have a fluoro. And again, modification of the technique using an ultrasound is again a good technique, because the guide wire can be seen by high frequency ultrasound. So we can see the guide wire going into the pelvis through an ultrasound. After we have the guide wire in place, we incise the anterior abdominal the skin. If you have intentions to put the deep cuff into the rectus muscle, then you have to make a bigger incision. If you are just trying to keep it over the rectus sheath, then you make a smaller incision so that the aesthetics are taken care of. And we make a blunt incision up to the anterior rectus sheath using a blunt dissection technique. And after that, we take out the dilator from the dilator Pilovis sheath set. And using the dilator, we dilate the tract so that the Pilovis sheath doesn't get squeezed up. There's a tendency for the Pilovis sheath to fold back on itself if you do not dilate it. So that is again some things which you see over a period of time. And this is also, I've learned it over a few catheter insertion and after a few mistakes. And once we dilate the tract, then it is much easier to put the Pilovis sheath dilator set, and it goes smoothly. Again, you have to keep a 45-degree angle so that the direction of the insertion is towards the pelvis. And the straightened catheter is now inserted through the Pilovis sheath. And once you hit the pelvis, the patient will have a small sort of urge of micturition or a slight pain. So if the pain, if the patient complains of that, then you know that the catheter is in the pelvis. Do not poke in more because you might injure the viscera. But since the stylet is not coming out of the silicone, so that chances are less. After that, you draw out the stylet and then slowly push in the catheter through the Pilovis sheath. And once the catheter is inside and the deep cuff is on the mouth of the Pilovis sheath opening, after that you slowly peel away the sheath, and the assistant will hold the catheter, the cuff, so that it is not pulled out, and the malposition chances goes down if you do that. So whether to fix the inner cuff or not, again, this is as per your convenience, time, and as far as your training is concerned. If you are new, then it is better to learn this technique because this causes a lesser chance of catheter malpositions and leaks, and even the surgical techniques becomes cleaner. But this was the initial purse string suture that we used to put when I was learning PD catheter insertions. Now I usually do not do it anymore because the removal becomes quite tough later on. So it is not possible to call the surgeon all the time for removal. So you can put a purse string suture along the anterior rectus sheath and then place the cuff inside the sheath and then tie the purse string. You use non-adhesible sutures for the purse string. A Prolene suture is good enough, and it keeps the cuff in place. So the chances of extrusion and leaks are less. But do not use the purse string suture if you're not surgically adept in removing it, because if you put it inside and you're not adept surgically to remove it, then the surgery becomes quite messy if you do not have an assistant. So how to choose the exit side once the deep cuff is in place? This is a rough way in which you can find out. Roughly around 30-degree from the perpendicular line drawn from the midline is the place where the exit side should be placed. Any exit side that is placed downwards or laterally is good enough. The exit side should not be above the superficial cuff, because it increases the incidence of exit side infections. And you can use the stylet to roughly find out where the exit side place should be. You mark it, and then you infiltrate that place. This is again another modification which you can do. You can bend the stylet so that it makes a curved track when you put it through the tunnel. And once you put it through the tunnel and the tip of the stylet hits the skin, you put a small stab incision and just dilate the incision by a blunt artery. Do not dilate it too much. The size of the exit side should be just enough for the catheter to come out, because again, the chances of infections, extrusions and all is much higher if you make the exit side too big. And once the stylet is out, you join the tip of the end of the catheter through the stylet, and then you pull it through the tunnel. Once the outer cuff is pulled through the tunnel, you feel a small tug when the catheter comes into position. So you know that the catheter is taut and there is no kink in the tunnel. So this is one of the problems that happens if you're not able to pull the catheter properly. Sometimes you tend to leave behind a kink and you're not able to find out that there's a kink. Only when you start the procedure, you find out that there's a kink in the tunnel and you have not taken care of that at that time. Once that is done, we close the skin with a simple mattress suture. A silk suture is good enough. You remove the stitches after 10 to 15 days, and it's a clean surgery and minimally invasive and less bleeding and less problematic. Now, this can be done as a daycare procedure. The patient can immediately go home after this procedure, and they can start eating if there has been no problems. A few things that was learned along the way as I was learning was that always point everything at an angle towards the pelvis. If you're not able to point the introducer needle, the guide wire, the dilators towards the pelvis, then there's a perpendicular insertion. And as the patient gets up, because the patient is supine, the anterior part of the abdominal wall tends to sag down, and the catheter has a memory, so it tends to snap back into the upper abdomen if the position is not maintained. And if you do not have a fluoro guidance, then ask for a bladder irritation sensation when you insert the guide wire, because that is one of the ways in which you can find out that the catheter is placed in the retrovesical region. Always keep track of the radiopic line on the catheter. Make sure that the radiopic line is never changed from one side to the other, because of the catheter memory. The catheter tends to get malpositioned in the process if you do not take care of that. And always, as it is, always never rush and be observant, because the complications that can happen in a catheter insertions are problematic. A bowel injury or arterial injury is a very disastrous thing to happen in the procedure. So this is the post-procedure X-ray of that patient. The catheter coil is very beautifully placed in the presacral region, and we know that this patient is not going to have any problems with the flushing, and there are no kinks, and things are going to be okay. After that, you flush the catheter with 1 to 2 liters of dialysate. You check for the outflow. You check whether there is any delay in the entry and exit of fluid. If there is blood in the exit fluid, weekly low volume flushes can be initiated, and break-in of 2 weeks. So if you are doing a percutaneous procedure in which you are placing the cuff right on the rectus sheath, then you have to at least observe a break-in period of 2 weeks so that the early pericatheter leak becomes less. If you want to initiate the catheter, the PD earlier, then it is better to place the inner cuff inside the rectus muscle so that the catheter leak comes down. And if we want to start the procedure much earlier, then low volume break-ins can be started if you have to do it much earlier than that. A few take-home messages is that always individualize the catheterization as per the patient. One type of catheter and one sort of insertion technique doesn't apply for all patients. Always offer CAPD as one of the RRT options and not as a salvage only method, because that will bring down your morale, because the salvage only patients, anyway, they are not going to survive for a long time, and you will start having a negative viewpoint about peritoneal dialysis. Always grasp the technique as per the guidelines and modify it according to the locally available resources. And if you have limited resources, you should always audit your technique as per the ISPD guidelines. So these are, and I think everybody knows this, a few audit data. So if your catheter insertion technique is meeting this audit data, then whatever you are doing is okay for the local resources available. So I think that is all. I would like to end the talk with a photo of one of my patients who does peritoneal analysis in one of the very, very remote areas of my state. And this patient is the one who had sent this photograph from near his house where this thing had happened. So I can very well imagine if he was in hemodialysis, what state he would have been. So yes, peritoneal dialysis is has to be learned by everyone, especially those who are practicing in the remote places. Thank you.
Thank you.